so much for the opportunity to speak to you all today. The title of the talk that I'm going to present on is very much focused on older adults, but it actually expands beyond that, which I'll show you as we go through the presentation. But the title is Data Linkage to Study Medication Use During Post-Acute Care in Skilled Nursing Facilities Among Medicare Beneficiaries. So to give you some background, Medicare beneficiaries frequently require post-acute care in skilled nursing facilities after a hospitalization. And after everything with COVID, I think many people may now be familiar with SNFs. They also go by the name nursing homes. So you probably know more about this setting than you might think. And hospitalizations from many different causes often require post-acute care. One example that might be relevant to this group is opioid use disorder, which frequently requires discharge to a post-acute care setting, often a skilled nursing facility. In some recent work with Patience Moyo, Eric Juckowitz, and Callie Thomas, we were curious to understand just how many older adults might actually have opioid use disorder hospitalizations, because much of the work that's been done to date has really focused on younger adults and middle-aged adults. And what we found is that there are about 75,000 OUD-related hospitalizations in older adults each year, which is a pretty substantial number. And what was particularly interesting was that 26%, so over 1 in 4 individuals, were discharged to a skilled nursing facility after an OUD hospitalization. We also found that 22% of older adults with an OUD hospitalization had experienced an overdose just before that hospitalization. So I wanted to point that out just to tell you, OUD certainly intersects with this topic, and medication use in general is very common during post-acute care and is often central to the treatment of conditions that commonly require PAC. And these include heart failure, hip fracture, lower extremity joint replacement, COPD, stroke, and of course, OUD. Not only is the initiation of multiple new medications common during PAC, but also the older individuals who receive PAC are often generally vulnerable to the effects of those medications and have even greater vulnerability during that specific post-acute care period where a lot is changing physiologically, and they may have just experienced a lot of changes during the prior hospitalization. So to give an example, appropriate pain control during that PAC period could promote participation in rehabilitation so that that person can regain function and go back home to their family, friends, and community. But overuse of opioids or sedating medications could potentially interfere with rehabilitation. And if that were the case, individuals might end up stuck in the nursing home and live out the rest of their days there, unfortunately. So similarly, another issue related to all this is that there's a lack of access to treatments for OUD in post-acute care. And this could really have important consequences because in some work that Patience Moyo is leading and I'm helping with, we've started to find that there are perhaps major barriers to receiving methadone, naltrexone, and buprenorphine during that PAC period. The treatments just simply aren't available during post-acute care. So despite the importance of medication use during PAC, there are surprisingly few studies of meds, including safety and effectiveness and just basic utilization. And we started asking the question, why is that exactly, if this is such an important place and period? And what we found is that large clinical trials are just unlikely to be conducted in post-acute skilled nursing facilities due to challenges with recruitment, consent, retention, and many other things. But then that raises the question, why aren't there more observational studies? And this is where a missing data problem enters the picture. So to study older adults, Medicare claims would appear to be the obvious data source for large observational studies of medication use, safety, and effectiveness during post-acute care. The majority of older adults are enrolled in the Medicare program. So why can't we just use Medicare claims? The issue is that observational studies using Medicare drug claims have not been possible because drug dispensing information is not captured by Medicare Part D claims while care is billed through that post-acute care skilled nursing facility benefit. And this is true for all Medicare beneficiaries universally. So to illustrate this in a diagram, what you see here is that you may have somebody who starts off in the community setting, so at home, and they may be having, let's say, opioids dispensed, and you can view that through their Medicare Part D drug claims. That person may then be hospitalized for hip fracture or opioid use disorder, whatever the cause might be. And during that period, the drug dispensing data is actually entirely unavailable. Similarly, when the person goes to the skilled nursing facility for post-acute care after the hospitalization, again, drug data totally unavailable. But if the person then transitions back to the community or to become a long-stay nursing home resident, you can again see their dispensings through Part D. And the reason for this is that hospitalizations and the SNF benefit are paid through Medicare Part A. And the services are bundled all into one single payment that doesn't allow you to break out what specifically the person received. So we set out to think about some solutions to the missing data problem. And when I say we, I mean Francesca Bowden and I, as well as our collaborators. So this is some joint work that we're doing that I wanted to tell you a little bit about. So if we were interested in just a small number of SNFs, a reasonable solution would be to use electronic medical record data from those SNFs if we had access to them or if the SNFs were willing to share it. The same solution might work well if we were just interested in a single chain of SNFs like Genesis or ManorCare, which are two of the largest chains. But what Francesca, I, and others were wondering is what solution would allow us to study individuals with a wide variety, meaning hundreds or thousands of SNFs with many hundreds of thousands of residents. So what we decided to do is approach long-term care pharmacies for the medication dispensing information. And there are two long-term care pharmacies that dispense medications for the majority of SNFs during that post-acute care period. The first is Omnicare, and that's a CVS health company as of a few years ago. The second is PharMerica. And Omnicare alone covers in excess of 60% of the SNF market. PharMerica is believed to cover another 20% or more. And so together, these two long-term care pharmacies actually dispense medications to 80 to 90% of all individuals in skilled nursing facilities. And our idea was to perform a novel data linkage of Medicare claims to this drug dispensing information for the post-acute care period. And we approached Omnicare since it was the larger of the two pharmacies. So to show you that figure again, now what you should see here is in the third box, rather than the drug data being unavailable, we could actually obtain this from Omnicare. So let me tell you a little bit more about Omnicare and why this solves our problem. So SNFs contract with Omnicare to dispense medications to residents. And Omnicare dispenses medications to those contracted SNFs, and as a result, actually has a complete database of all medications dispensed to all residents who receive their drugs through Omnicare in those SNFs. And the data is independent of payer and health insurance plan. And this is really important because it actually means that the data is universally available, regardless of what type of Part D plan you may have or any other characteristics. You can also see actually dispensings for individuals covered by private insurance and programs other than Medicare. And so Omnicare is actually able to therefore fill in that medication data that's absent from Part D claims during the PAC period in SNFs. And the data looks a lot like Part D data. So it has national drug codes that allow you to identify the drugs. The data has a similar structure to the Part D claims. And just like Part D, it's maximally useful when it's linked to other data sets that contain information on demographics, medical conditions, geriatric syndromes, and SNF characteristics. So that's exactly what we decided to do was after obtaining this data, hopefully link it to other data sets. And this is work we're currently hoping to begin on very soon if we can get the data from Omnicare. So the Omnicare data could be linked to the Medicare enrollment file, hospital claims, outpatient claims, drug claims, and nursing home facility information. And you may be wondering, why link to Part D drug claims if we already have the drug dispensing info? And there's actually a few reasons. The first is that you would want to know the pre-hospitalization medication use information in many cases. You also would want to know when the person is still in the nursing home but no longer on the SNF benefit, are they still receiving these drugs? And you could actually, in that case, compare to the Omnicare data for some validation. And then finally, when the person leaves the skilled nursing facility, you would want to be able to use the drug claims to again examine their community medication use. So I have a few details here about the matching. I'll kind of go through that quickly. It's deterministically done, and it uses the following information from the beneficiary. And it's performed by a contractor of the Centers for Medicare and Medicaid Services. So what I really wanted to do today was just tell you a little bit about the linked data resource, because I think it could open up a number of new research lines that folks here may be interested in. And this new linked data resource, once it's available, will have quite a lot of information. It has many of the standard data elements you would find in claims, but also from other data we link to, it has really unique measures like cognitive impairment and physical functioning, which we obtain from standardized nursing home assessment data. So it would be possible, for example, to understand how opioid use impacts somebody's cognitive and physical functioning, or how perhaps not receiving medications, such as medications for OUD, might impact somebody's overall well-being, physical functioning, and cognitive functioning. And I've actually just put out a few possible research questions here on this next slide, which include everything from PAC medication utilization, including use of meds for OUD, which we know almost nothing about right now in skilled nursing facilities, the effectiveness and safety of post-acute care medication use as an outcome of prior inpatient care, such as, for example, by level of quality of a given hospital system, and effects of policies or insurance design on post-acute care medication use. So how the design of an insurance plan, for example, might influence subsequent use in PAC. And of course, there's really a lot more questions that could be answered. So the two takeaways I wanted to leave you with from this brief talk are that there's an important missing data problem that precludes studying post-acute care skilled nursing facility medication use with Medicare claims alone. But linkage to Omnicare helps to solve the missing data problem, at least partially, and open up new previously hindered lines of research about medication use during this critical post-hospitalization period. So I'm going to leave this there. I have to, of course, acknowledge CVS, our collaborators, especially Francesca, funding we have from the National Institute on Aging and Advanced CTR. And I also just want to draw your attention to this report, which I didn't talk too much about at the beginning, just to stay brief, but we just completed a technical brief for the Agency for Healthcare Research and Quality on the prevention, diagnosis, and management of opioids, opioid misuse, and OUD in older adults. And it was quite shocking and also very disheartening to find that there's very, very little evidence on any of these topics in older adults, especially opioid misuse and OUD. And, you know, I think a lot of research, media attention, policy has focused quite a lot on younger adults and middle-aged adults for many good reasons. But I think it's important to realize as well that older adults have lots of the same health challenges and almost nobody's looking at them. And we don't really have an evidence base to guide care. But, you know, my personal opinion is that these older adults deserve just as good quality of care as the younger and middle-aged adults. So I hope that maybe I could encourage you to think about some older adult questions in your studies, or please, by all means, you know, approach me, Francesca, and others about moving into the older adult space if you think you might have any interest. So thank you. I'll leave it there. And I know we have time for questions now, but, you know, Elliot is also going to give a talk, so I'd be happy to wait until the end if you'd prefer. Thank you.
Andrew, that was really fantastic and very exciting. And of course, my thinking is going right to how do we get you to help us with the younger people using this data set? Because, one of the issues that we kind of bumped into at these facilities is we have this wave of this opioid epidemic now. A lot of people getting hooked on opioids, injecting, getting endocarditis or other serious infections that require 4, 6, 8 weeks of IV antibiotics, and they have social issues, and so they should go to these SNFs, post-acute care facilities to get their care, because of course it's too expensive to keep them in the hospital. And the Justice Department has started started litigating cases using the Americans with Disabilities Act to force, I think one of the first cases was a SNF in southeastern Massachusetts out of the Boston office. And because people who have opioid use disorder and are on treatment are a class of disabled adults by definition, and to discriminate against them, which is what happens across the entire country. Now, I've talked to other people about that who said, "Oh no, these are bad predators. These bad drug addicts, based on no objective evidence, and you can't put them in with these poor little old ladies in the nursing homes with all these other problems." So I think thinking about that data is like, wow, there's probably a lot of these young people in there, and you could probably look at not just their you could look at maybe you can get their diagnoses, you can get their meds pre and post, but also you can get their if they're on prolonged antibiotics, and maybe make some assumptions about why they would need the antibiotics for that long, and find out probably that most of them are not getting the MOUD, and that could, you could actually drive some change there. And if those young people get treated, then let's start looking at the older people. Now, the older people now are the baby boomers that, sex, drugs, rock and roll was our credence. And now we're all ending up hospitalized. And I was just thinking of a patient I saw yesterday. He's in his 60s and he's had opioid use disorder for 40 years. He's on stable prescribed opioids, but he has opioid use disorder. And I think a lot of people on methadone, somehow get transitioned over to prescription opioids because they can't drag themselves to the program every day. They have opioid use disorder and they're on chronic opioids. So I think actually pushing that agenda of opening up these facilities to MOUD is going to help the younger people that need the help now, and the older people that also need the help but have not been getting it. So very exciting. I will stop and see if anyone else has some thoughts.
If you don't mind, I'll just respond really quickly, which is to say, so when I worked as a pharmacist at Rhode Island Hospital, I frequently saw what you described, where actually many younger people are sent to skilled nursing facilities for intravenous antibiotics over a long multi-week or multi-month duration of therapy. And you're absolutely right that about 10 to 15% of the skilled nursing facility population is individuals under the age of 65. So it's a fairly substantial number of people when you consider about 3 to 4 million individuals in any given year pass through skilled nursing facilities just for post-acute care. So I think there's a lot to be done there. And this data set would answer those questions just as well for younger adults as for older adults. And to highlight some of the issues that you're talking about, I wish Patience, I don't think she's on the call, or Callie Thomas were here, but we've had a number of discussions about what's happening anecdotally from speaking to people in these facilities. And we've heard that in many cases, people just simply don't receive medications for OUD. They're just withheld. In other cases where the facility does recognize the importance of those medications, what they've done is they've actually put people in ambulances and sent them to an outpatient clinic to to go get those drugs, which is enormously expensive. Just think about an aggregate, like the cost to the Medicare program and the healthcare system of doing that, because an ambulance ride each time, each way, every day, or, you know, whenever you need these medications is just like astounding to me. So there's really like some important questions here that I just think like almost nobody's really thinking about or looking at. So I'll leave it there. And I think others probably have questions.
The other issue that happens is people leave against medical advice because they're not getting what they need, and that's not in anybody's best interest. So that, I don't know if you have ability to look at that in your data set, but if they're leaving prematurely, that would be very useful to know. How close are you to getting the data set from CVS Omnicare?
So that's been the biggest challenge in all this work, because CVS very rarely partners with academics. So there's been just a real number of hurdles that Francesca and I have had to jump: legal, data security, et cetera. Then the pandemic happened, and CVS said probably in the spring, but you know, we're in summer now. So I wish I had a better answer on that, but hopefully in this calendar year, I think is probably the best I can say.
You should talk to Tracy, who's had experience with them.
I'd be happy to talk with you, Andrew. Yeah, and Francesca.
Offline.
Yeah, definitely offline.
Super, thanks.
So while I have the mic and I have your attention, I wanted to actually ask you how, you know, a perennial challenge, and we heard it even last week with the Boston Fed Talk, it's around race, ethnicity, and actually even gender and sex, biological sex. How are those kind of captured in kind of what you've been working with so far? I sense that I would anticipate similar disparities along the racial lines on of OUD treatment in the community in skilled nursing facility as we're seeing elsewhere, but very important to look at the data and ask. But just curious, are there workarounds or improvements in this linkage approach?
Yeah, I couldn't agree more. I bet we've seen for a number of different things that disparities in the community setting are often mirrored in the post-acute care and long-term care settings. Sometimes they're actually worse because all of the person's care is sort of at the mercy of the staff who provide medications, provide the services. And you can imagine if there was some staff bias, that could actually exacerbate disparities. But empirically speaking, we know nothing really about OUD medications and disparities and things like that right now. We have a little information that says many facilities outright refuse people with OUD, and that there's also some racial bias in people being able to enter post-acute care facilities, which are two problems that are distinct yet intersect. But in the data, to directly answer your question, we have race, ethnicity information. And it comes from the Medicare enrollment file as well as the MDS. And then there are algorithms that have adjusted those race variables based on individuals' last name and other characteristics to try to better ascertain Hispanic ethnicity. And then in addition to that, there are some other newer algorithms that may even further enhance that. And in the MDS data, we used to have preferred language spoken as a pretty well-populated variable, which could be used to even further perhaps isolate certain ethnicities. So, and sex is definitely there as well.
Great. That's exciting.
Thank you. We have a question from James Rudolph. James, if you could unmute and ask your question.
Hi, Andrew. I just wanted to highlight that I'm in a little bit of disagreement about skilled nursing as an optimal environment for opioid use. And that's not that we shouldn't do any opioid use, but a lot of these facilities, we like to think of them as mini hospitals, and that they are not. You know, they are really bare bones organizations with lots of turnover, and opioid use management is a skill set, and not all have adapted. It doesn't mean we shouldn't move towards that, but currently, I think there's an incentive for hospitals to, quote, park people, end quote, outside their doors in skilled nursing, and I think it's a bad setup.
Yeah. So I have to say, optimal changes that whole statement for me because I think I'd have to agree. It's probably not an optimal setting. There was, I think, an article perhaps last year that was focused on the comparative effectiveness of different treatment pathways or settings for opioid use disorder. I was really excited when I saw that come out. I think it might have been in one of the JAMA family journals. And I thought perhaps they would have included post-acute care settings like SNFs, and perhaps, other settings in which we know people are actually getting quite a bit of care for OUD. But those settings were entirely left out of the analysis. I think primarily they had focused on like inpatient and outpatient rehabilitation settings. So we actually have no clue, I think, how SNFs compare to some of those other settings, even though they are being used as a treatment setting for quite a number of individuals. So yeah, Jim, I don't know the answer to your question, but I totally understand where it comes from, and I'd love to see that data. It's just yet another, question we don't have answered for people.
Thanks.
I would point out that most people who are exposed to opioids are not, and I'm sure the same is true for the elderly, are not going to develop opioid use disorder, even if they're daily dosed to the point where they do get physical tolerance and withdrawal. They're not going to develop, opioid use disorder. So I guess I was a little unclear about your question is for opioid use in these facilities. Are you talking about treating opioid use disorder, or are you talking about somebody is rehabbing from something and they need enough opioids to?
No, I actually think the facilities are relatively attuned to pain and can deliver some opioids. So if you have a hip fracture or a hip replacement, I think that's well in the scope of what they're doing and what they're capable of doing in the current time. I think if there's someone who's an addict, comes to the hospital because of their addiction, and the pathway is the hospital can't decide where to move them to because they're preserving their length of stay, and the choice is inpatient rehab, which is expensive, or like inpatient opioid use disorder rehab, or skilled nursing, which is a cheaper option. I think it often gets turfed off to the skilled nursing facility, which is not. I don't think that the patients get the care that they need there. There's not the mental health support. There's not, it's not a hospital. It's not a treatment center. Those are my points.
So I would suggest that most people with opioid use disorder walking through the door, I have a problem, do extremely well on buprenorphine. And that's really all they need. They don't need complicated mental health services. And, and so I think, people have this idea that these are, bad people, they're predators, they're going to be disruptive, they're going to be causing all kinds of trouble. And the truth is, we in the medical field have not provided appropriate treatment. So when people are not getting what they need, they do act out. They do whatever they have to do to get, because their body at a subcortical level is telling them to get that opioid in their body or they will die. So they do act out. They do whatever kind of desperate things they have to do. But once you take care of that, a majority, more than 50%, that's all they need. You sprinkle this little medicine on them and they do really well. So I would just say that, I'm excited to look at the data, but I would suspect that most people don't get the treatment they need. And the treatment is mostly just the medications. And I think, for those people that are, have serious psychiatric issues and other underlying, severe stress issues and, post-traumatic stress disorder and all kinds of other things, they're going to need extra services. And I would agree, some of them may not be appropriate, but I've just been amazed at the power of these medications to address this disease.
And like I mentioned in my comment, it may be a new skill set. we need to figure out. But it's, you know, it's not a skill set that exists en masse in skilled nursing right now.
Oh, yeah. Or in the entire medical field, I would suggest. But it's not that hard a skill set to get for most people. Most people, simple opioid use disorder, pretty straightforward.
Great. Well, thank you. Lori and Diana, I know you have questions, but if we could hold those to the end of the meeting, that would be great. And we can give Dr. Bosco a chance to start his presentation. Thank you, Dr. Zullo.
All right. Yeah, I wish we had another hour. This discussion is really, really great. And I'm going to try and speed up my presentation so that we have, you know, some time for good discussion. Let me just get my slides ready. And let's see here. Okay. And can everyone hear me all right? Yep.
Sure
Okay.
can. Yep.
All right. So thanks everyone for attending. I'm very happy to share my study, Postoperative Safety of Tramadol among older adults following total hip and knee arthroplasty. Andrew's presentation ties well into this study as I considered postoperative prescribing and outcomes, and there was some analytic decisions that I had to make due to the missing data problem that he just described, and we'll talk about that more. And so, just a second. So I'll go with an overview of the issue, and I'll give some background on my study, and then we could have our discussion at the end. I will try to move quickly through the methods because I'd like to hear your thoughts on the findings at the end. So an overview, many older adults suffer from osteoarthritis, the most common of which is hip and knee osteoarthritis. And due to the progressive nature of the disease, most individuals will eventually qualify for total hip and knee arthroplasty, procedures with demonstrated effectiveness and improvements in quality of life. As the population of US older adults grows, so will the demand for hip and knee replacements. And so opioids are commonly used to manage pain immediately following hip and knee replacements, and approximately 40% of older adults are at risk of first-time opioid use. Tramadol, which is the focus of the talk today, is a weak opioid agonist that is increasingly used as an opioid-sparing form of pain management. The table on the right demonstrates tramadol's low potency relative to oxycodone and hydrocodone based on the CDC's morphine milligram equivalent conversion factors. Due to tramadol's low potency and theoretical low abuse potential, tramadol is in a less restrictive DEA Schedule 4 compared to other opioids in the more restrictive Schedule 2. This may give the impression that tramadol is safer as an opioid light. However, based on tramadol's pharmacology, which we'll discuss shortly, others have deemed it tramadone. And so on this slide is some preliminary work that I did to understand postoperative prescribing trends using Medicare Part D data. And this focuses on the 30 days after elective hip and knee replacements among individuals with no opioid use in the 180 days prior to their procedure. And what I want to note here, just trying to save some time, is that the black line is tramadol, which has seen increased use over time, and hydrocodone, which was commonly prescribed, has actually seen decreased use over time. And if we had additional data, this goes to the end of 2017, it's likely that tramadol has actually overtaken hydrocodone in terms of postoperative prescribing. And so tramadol is becoming increasingly popular, but is it actually safer? To start, tramadol has two mechanisms, one as a weak opioid and the other as a serotonin norepinephrine reuptake inhibitor, or an SNRI. When taken, tramadol requires metabolism for its weak opioid properties, but before that, it's a prodrug that is primarily serotonin norepinephrine properties, the SNRI properties. I have the sleepy brain here because both opioids and SNRIs affect the central nervous system and may cause sedation, which carries the risk of adverse events with older adults. So to further expand on tramadol's pharmacology, it requires CYP2D6, the CYP2D6 enzyme for metabolism. Many drugs inhibit the CYP2D6 enzyme, such as common antidepressants like paroxetine and fluoxetine, which would effectively stop the conversion of tramadol to its weak opioid form. On top of that, approximately 10% of the population are poor 2D6 metabolizers, which would further prevent the conversion of tramadol to its weak opioid form. Taken together, this further increases the chance that tramadol remains in its primarily serotonergic form. And so all in all, you effectively roll the dice when you prescribe tramadol, and the effect of therapy can be wholly unintended, particularly if additional serotonergic, opioid, or other CNS active drugs are prescribed among older adults. And so with that, the safety profile of tramadol is really unclear. And studies of tramadol safety are limited and insufficient for several reasons. First, active comparators are not commonly used, which may bias findings due to unmeasured confounding. Also, there's lack of a common time zero, which limits the homogeneity of populations studied and further increases the potential for bias. Prior studies have also not accounted for the time during which individuals are on active therapy, and failure to do so may obscure the association with safety outcomes due to the discontinuation of treatments. And so the approach I took in this study tried to improve upon some of these limitations in the prior literature. And so again, I'm going to try and go quickly through I don't actually see the time here because of the modem. And Gail, would you give me like a 10-minute warning at the end just so I could
Absolutely.
plan accordingly?
Yeah, absolutely. We're at 12:12 right now, and
Okay.
Andrew was able to answer the additional questions via chat, so you should be good to go. Yep.
Okay, so I'm going to try and motor through the method section. Also, there's some common pharmacoepidemiology terms which may be unfamiliar to many of you. I'm also happy to elaborate on some of those concepts during the Q&A or even afterwards offline. And so the data sources that I used today were primarily Medicare data, as I focused on a Medicare enrolled population of older adults. I want to highlight the 20% random sample of Part B and D claims. That is the largest sample of these data sources available to academic partners for the general Medicare population. And also, I want to highlight the residential history file, which is a validated algorithm of different post-acute care assessment data and claims data that allows for the tracking of individual health service use, location, and the timing of post-acute care utilization. And so the retrospective cohort study I conducted took place between 2010 and 2015 before the US's ICD-9 to ICD-10 diagnosis conversion. And this is a new user active comparator study design, which is meant to eliminate the possibility for unmeasured confounding. I also have some selected inclusion criteria here that were meant to make the population as homogeneous as possible. So these were Medicare fee-for-service enrolled older adults age 65 plus that received elective hip and knee replacements. They were continuously enrolled in Medicare, had no opioid use in the 180 days prior to their procedure, and they were discharged home only with or without home health. So I excluded individuals who were discharged to a SNF after their elective hip or knee replacement or inpatient rehab facilities because of that missing data problem that Andrew described earlier. And so if we had the data available, we could actually study those individuals, but I excluded them from this analysis. And so this is a basic study design of what I did. Essentially, day 0 is the date of the elective hip or knee replacement. And afterwards, I assessed for the initiation of Tramadol, Oxycodone, or Hydrocodone during the postoperative period and followed individuals forward for their outcomes. So as I mentioned, I used Part D, and my goal was to compare Tramadol to Oxycodone and Tramadol to Hydrocodone. And I assessed use out to 90 days. And I also required that individuals began their therapy within 7 days following the procedure. The outcomes that I considered were all-cause inpatient hospitalizations and ED visits, and also specific serious adverse events as a composite endpoint based on outcomes that might be opioid related. And I also assessed those out to 180 days. I assessed negative control outcomes, which are outcomes that should have no relationship with the therapy that was prescribed for postoperative pain. And so these were a form of assessing for the presence of unmeasured confounding when making the treatment comparisons. So the analytic approach, and I'll just go through this quickly, relied on specifying marginal structural models to assess for the 90-day average hazard ratio. And I also estimated inverse probability of treatment weights and censoring weights in order to calculate both the intention to treat and per protocol estimates of safety. And so I also estimated these at 30 days, 60 days, and 90 days following the procedure. And as I mentioned, I estimated the intention to treat effect, which is as randomized, that is naive to the individual's adherence to therapy, whereas per protocol is the as treated effect, and that is the treatment effect when the individual is adherent to therapy throughout the duration of follow-up. And so I fit a generalized boosted model for the propensity for the inverse probability of treatment weights, and for the censoring model, I fit pooled logistic regression models among each arm and separately for each outcome. And again, I'm going quick, but we can, during the Q&A, we could speak more about this. And so finally, I used a weighted pooled logistic regression model for the outcome model. And so the results, there were approximately 29,000 older adults included in the final sample. Tramadol users were the smallest group and were notably older than either hydrocodone or oxycodone users. And Tramadol users also notably differed based on other baseline covariates and had a higher prevalence of comorbidities. Due to this, it raises the concern that there might be preferential use of Tramadol among older and sicker individuals. This is called confounding by indication, and it is important to consider when we interpret our results. And so here I have presented the outcome incidence across treatment groups. For the intention to treat effect, there was approximately 13 to 15% incidence of all-cause events, and serious adverse events occurred with an incidence of just around 3%. The per protocol effect, the incidence was lower, with all-cause events ranging from 8 to 10% and serious adverse events around 2%. Here I have presented the hazard ratios for each negative control outcome for tramadol and compared to oxycodone. Since all of these hazard ratios overlap with 1, it suggests that there's no bias due to unmeasured confounders. However, recall that there's likely confounding by indication, which may bias our results. That is a form of unmeasured confounding. And so here is the tramadol and hydrocodone comparison. Again, there's no apparent bias due to unmeasured confounders. Here, when you look at the average 90-day hazard ratio, you can see that as you progressively adjust for baseline, this is the unadjusted effect, but as you adjust for baseline covariates with the intention to treat effect, and then you adjust for adherence, you see that an increased risk of all-cause events actually becomes non-significant. And for the serious adverse events, you see that there's no significant increase in risk. When you look at the tramadol versus hydrocodone comparison, you see that even after adjusting for treatment adherence, there still is a significant increased risk of all-cause events at around 33% increased risk, but no significant difference for serious adverse events. And so when we look at the period-specific 30-day, 60-day, and 90-day risk differences in hazard ratios for the all-cause events and intention to treat effect, we see that there is a significant difference at 30 days between tramadol and hydrocodone, but this does not hold for 60 days and 90 days. When looking at the per protocol effect for all-cause events, there is similarly an increased, there's a significant difference between tramadol and hydrocodone, meaning an increased risk of all-cause events with tramadol use compared to hydrocodone at 30 days, but this does not hold for 60 days and 90 days. And when we look at the serious adverse events endpoint, there is actually no difference among the treatment comparisons for the intention to treat effect, and also not for the per protocol effect. And so some limitations of this analysis.
Elliot,
yep.
I'm just going to interrupt you. You are at the 8-minute mark.
Okay, so
yeah.
just to conclude, we can only observe filled prescriptions covered by Part D. We can't observe prescriptions paid for by cash. And we're missing some information on potential confounders, such as baseline and follow-up pain scores, as well as the history of osteoarthritis and the duration of severe pain, which could influence an individual's pain treatment requirements at the time of their procedure. And then again, as I mentioned, confounding by indication, tramadol users were older and had a higher prevalence of comorbidities. So it suggests there might be preferential use of tramadol among this group. And this analysis didn't incorporate other common postoperative medications. So for all intents and purposes, tramadol does not appear to be different than oxycodone or hydrocodone for opioid-related outcomes. There was a difference for all-cause events, but it's unclear if that was due to confounding by indication, like I mentioned. And so, in my opinion, based on tramadol's messy pharmacology, as I mentioned at the beginning, and generally safe, similar safety profile across agents, I actually wouldn't recommend tramadol's use among older adults. Instead, I would opt for low dose and monitored use of agents like hydrocodone instead of tramadol. And so that's that. I know I went very fast, but yeah, what questions do you have?
That was really great. I have a question. I have to ask.
Yep.
We are seeing tramadol illicitly being used as an active cut to augment fentanyl's presence in the illicit drug supply. What do you think of that as perhaps a choice of active cut as opposed to maybe more fentanyl or only fentanyl, for instance? It's also been a COVID era thing, not something we've seen forever. But are you surprised? Is that a good choice, bad choice?
Well, it's surprising.
Based on your results?
It's surprising to me. I mean, I wouldn't think it would, enhance the opioid effect by any means. It may just be easier to obtain, because it is Schedule 4, and it is something that, for the most part, is viewed as relatively benign. And so it may just be ease of obtaining it. It could also be, although I don't know that this would be the case, it could be that this is a safer opioid, but I don't know that that's widely known in the general public. So yeah, I think it's ease of access, if I had to guess.
Great. It's very interesting based on your findings and such. Thank you very much.
Steve, you had a question?
Yeah, thanks. Really great study. Outcome studies on tramadol are so needed, particularly given how it's just growing in use. I'm wondering if the conclusion from your study might persuade folks to use or prescribe tramadol, in that, believing that perhaps it's, there's no safety risk, but, there are some other outcomes that, weren't as easy to measure, I suppose, like seizure, maybe pain control, and of course, all the polymorphisms and drug interactions as well. So I don't know, are you wrestling with that in any way?
I am, because for the most part, these findings, I wouldn't say they're inconclusive, but they definitely don't provide the strongest direction, for how practice should change. I think when you look at everything in totality, it suggests tramadol may not be best, but if you take one study, you can kind of interpret this as you may. There are other outcomes. So like you said, pain scores. I would love to do this study again and understand with either survey data or something like that, how pain differs among these populations. Seizures too. So I focused on opioid related outcomes, but that serotonergic piece, with tramadol, not being converted to its weak opioid form, does open the door for things like serotonin syndrome, seizures with the seizure threshold, and that could be potentially important too, particularly among older adults who are prescribed many different therapies. So yeah, I think there's a lot more work to be done.
Thank you.
I was kind of curious looking at this as a, you have a composite outcome there, but, the sort of dreaded outcome of using opioids, and what a lot of the hysteria and pressure to take people away from prescribed opioids is the concern that people develop opioid use disorder and or overdose. Do you have a sense of how either from this data or in general, how many people develop opioid use disorder?
Yes.
I will point out that even though it's a Schedule 4, you still have to, when you're doing electronic prescribing, you still have to sign away your life.
Right. There's still a barrier. Right. It's not like it's not like you could go pick it up, like Sudafed or something, just show your ID. It's still, so that's a great question. I actually did look at all opioid related ICD-9 and ICD-10 diagnosis codes. So I didn't restrict to, anything that might, I know there are some codes that specify opioid abuse or, things like that. But it was among this group of people, it was extremely rare. It was 0.1% of my population. And so that was when I initially set out to do this study, that was one of my explicit outcomes. But due to the rarity of the outcome, I did have to, create a composite endpoint.
Tracy with the Y, you have a question?
Am I unmuted? Okay, there we go.
Yes. Yep, you're ready to go.
Hi, I've done some preclinical work assessing abuse liability at the preclinical stage. And one of the things that's interesting is this temporal disparity between actually taking the drug and the resulting metabolite, which takes a fair amount of time.
Mm-hmm.
In rats, it's much quicker, 15 to 20 minutes for the O-desmethyl tramadol to accumulate. But I'm curious if you know the relative percentages of some of these individuals that have a very high 2D6 liver enzyme that is
ultra rapid metabolizer.
Yeah, like something that, because I'm aware of several cases of people that readily take 400 milligrams at a time.
Yeah, this was something I really tried to dive into. The limited evidence, so that's, long story short, is there's limited evidence about this, but there are reports of people having very severe opioid related, response because they are ultra rapid metabolizers. But all in all, I believe it's between 6 to 10% of individuals are ultra rapid metabolizers. But this does vary based on genetics, family history, things like that. So, there's more work to be done in that sense. Yeah, does that answer your question?
Yeah, more or less. I'm also aware of like a study that was done a while back where basically hardcore addicts that have used heroin they did a study where per os administration of I think like close to, I think it was like 200 to 400 milligrams was rated relatively high by in terms of the amount of euphoria produced among chronic heroin users.
Yeah, no, that is interesting, but in that sense, there's more work to be done and very limited evidence on how people's 2D6 phenotype actually influences their, responses and potentially adverse events.
And sorry, just
okay.
One more quick question. Was it like 2014 that it was actually scheduled? Because I know there's a huge gray market pharmacy in the early 2000s where people could just click on the internet, go to these sort of gray market pharmacies with.
Yep. It was mid 2014.
Mid 2014.
Both hydrocodone and tramadol, and there was actually much more decrease. Yeah, what did I say? Hydrocodone and tramadol. There was a greater decrease in hydrocodone use, but still a steady increase in tramadol use, even in the midst of those changes.
Interesting. Thank you.
Yep.
So we're at time, but Elliot, if you have a few minutes, we've got a couple other questions.
Sure. Yeah.
Yeah. Lori D, you had a question?
Yeah, I did. I had a couple of questions actually that I wanted to know about if any research was done on those with on people in recovery as far as reinitiating cravings and those who were previously dependent. And I just encourage everybody that when you're looking at people with opioid use disorders, that you consider those in recovery that are getting older, because those are the ones that are really at high risk for relapse.
So what I did try to do in this study was actually exclude individuals with any history of an opioid related diagnosis. And it, again, like I said, it was a very small group of people. But I did try to exclude those people in the event that, you know, they do potentially relapse, or it could just be something that's on their record. Not their record, but it appears as a secondary diagnosis as they receive other elements of care. So I didn't want to be picking that up.
Yeah, so my question was really for both of you around the
What work has been
prescribing
done.
for adults with unknown alcohol use disorders.
Oh, okay.
So, you know, I don't know if any of the data has looked at a previous diagnosis of alcohol use disorder for any of these patients.
So some of the literature, I haven't, it's a little bit beyond the scope of what I've done, but from what I know is that, you know, individuals with a history of alcohol use disorder have an increased risk of going on to have long-term opioid use. The jury's out from, you know, in terms of them having opioid related adverse events. So, but that's about the extent of what I know. Does that answer, does that provide any clarity or?
Yes, yes. And I was wondering about the previous presenter too, if that, if those diagnoses were looked at for any kind of substance use disorder.
So Andrew dropped off, but that,
Oh, okay.
the report that he did conduct with other members from the Brown's sesh, that has, it's pretty much the state of knowledge on alcohol use disorder and other risk factors for long-term opioid use or opioid related outcomes among older adults. So that is definitely captured in there, and I would definitely urge you to check that out. I could even email it to you if you'd like.
Oh, that'd be great.
That'd be great.
I'll put my email in the chat.
Yeah, I can connect the two of you because I
Thank
have
you.
both of your emails. So that was really, really great session. Jody, if you want to do a quick close.
We should send that all the way around.
Yeah.
Make that available.
Yeah.
Yeah, I just want to really thank you and thank the audience for hanging in there. This is a sign of a good talk, is a good discussion afterwards. And
Great discussion. Yeah.
so thank you so much. And,
yeah. Well, thank you all. This was really a pleasure, and it was great to chat and hear all your thoughts too.